Okay. Well, good morning, everybody. Thank you so much for joining us for this month's Women in Business meeting. We are partnering with UTMB Health once again this month. They've been an awesome partner with us for our Women in Business series, presenting different topics on women's health. So we have another great presentation today. I want to introduce Becky Chart-Umbehagen from UTMB Health. She has been working with us here at the Chamber to line up some great doctors and presenters to cover different topics. So Becky, welcome. You want to get us started?
Sure. Thanks, Jessica. We have a wonderful topic today for you. I think you'll find this really interesting. We're delighted to be back for Women in Business again and to share some more expertise and some of our great docs with you for this program. I do want to just do a quick reminder, if you have been delaying that preventive health care or not taking advantage of telemedicine or other opportunities, get in and see your physicians for your existing conditions, please don't forget to call and schedule those appointments. It's incredibly important to get in and see your physicians and healthcare providers for those things. So now to introduce our speaker, I'm going to pass it over to my colleague, April Ciccarello. April.
Great. Thanks, Becky. I just wanted to say welcome, everyone, and thank you again, Jessica, for having us today. So we'll get started. Ladies, do you have burning questions about bodily changes, but you're afraid to ask? Well then, hold it. Let's talk about incontinence and pelvic health. UTMB brings you our speaker today, Dr. Gökhan Kilik, who is the Director of Minimally Invasive Gynecology and Research in the Department of Obstetrics and Gynecology at UTMB Health. Also joining Dr. Kilik is nurse practitioner Nikki Milburn on the call today, who practices with Dr. Kilik. So I just wanted to say hi to Nikki. Dr. Kilik is board certified in obstetrics and gynecology, female pelvic medicine, and reconstructive surgery, and is a certified fellow in fundamental laparoscopic surgery by the American College of Surgeons. Dr. Kilik is also a fellow of the American College of Obstetrics and Gynecology. He was one of the earliest recognized robotic gynecologic surgeons in the Houston area, and also he is a pioneer of single incision robotic hysterectomy. He was trained in minimally invasive surgery at Mount Sinai Hospital and has worked at prestigious hospitals including Georgetown University, Albert Einstein College of Medicine, and Parkland Hospital. Dr. Kilik came to UTMB from MD Anderson Cancer Center to UTMB's dynamic team, offering women minimally invasive gynecology and services related to public health and urogynecology. As a subspecialist in urogynecology, Dr. Kilik has a special interest in helping patients address urine incontinence. This is what we call leakage. He will discuss diagnosis and treatment options with us today, as well as pelvic prolapse, reconstructive surgery, and other important gynecological issues for our personal health. Welcome, Dr. Kilik, and thank you for talking with us.
Thank you. Thank you very much for the warm introduction, April. I appreciate it. And actually, today, I wanted to summarize and focus on the two main issues that related directly to the woman's health. And 20 years ago, when I started this OBGYN field, I just wanted to understand first what woman thinks, and then what your client list would be demanding from you. It starts with the understanding the woman's, initiation, the health issues that I can help with. So we can start the slides if you could from there. So wherever I go, I have been given lectures over 30 countries now in globe, and I always ask women what they want, and then I've been summarizing throughout the years those some of the issues actually. And if any of you guys are disagree with the following topics that I picked along this time, and please let me know, or if you wanted to add something, and I'll be happy to learn from you guys. So that's one of them, feel loved, and move on just quickly, we can move on. And as I said, if there's any objection, just let me know, please. Understanding that another common topic globally, quality time, conversation, to be heard. I hear that a lot from my wife, actually. Help with daily work, to take care of themselves. Themselves meaning to take care of to their spouses or their significant others. That's projects, instead of taking care of the whole family, if the partner takes care of himself. And the next one is the last one, is the most important one. It's always on top of their list, actually. The trust is the main thing in the woman's, the book that globally takes the most significant part of their demand. When you say demand, actually, the woman, they don't demand, they just, kindly request it. And how do I know that? Because look at this, the next slide. Next slide. I was in Ireland in a local newspaper. I was looking at it, and while I was waiting for my ride to come, I saw this local newspaper, and I caught this is the cover page of it, and I saw the topic, and I was interested in. So I flipped the pages, and next page, they summarized it in an Irish newspaper. They want power, they want love, they want equality, they want better sex. The interesting part, actually, toward the end, one of the demands at the bottom of the list is the Putin's head on a stick. I guess Irish women, they have something against Putin. But it's not our topic. Our topic is actually women, they know what they want. They summarize it very well. And it's a globally shared topics, actually, among the women. Just next one. But as I said, they don't demand. They just request that nicely. The women in today's real world, they still make less money for a dollar compared to men. And we are talking about the developed countries here. But in the same country, in the US, we pay, the insurance companies, they pay $780 million per Cialis per year. And insurance covers most of it. And the next one. And then we spend $170 million per year again in the US for the penile pump, the device. And then the insurance covers. When I started doing the robotic hysterectomy initially, 15 years ago or so, and the insurance companies were giving me a hard time. They were saying that, no, you were doing it laparoscopically, you're doing it just fine, and why don't you just keep doing laparoscopically? Robotic is more expensive. And, every other case I had to appeal to the insurance companies to get paid for their hysterectomies. But at the same time, they never raised a question when the man was having a prostatectomy robotically. The robotically, you see better, the visualization better, you preserve the tissue better, you bleed less, and yet when it comes to the woman, it's a health issue. You have to, challenge them. You have to push for it to get it. But from day one, the prostatectomies was not a problem at all from the insurance company point of view. So next one. We can go, this is me, and this is the UTMB. UTMB is the first medical school in South of America, meaning whole South. It's not only Texas. In the whole South Texas, whole South US, UTMB is the first medical school. And I'm proud to be part of it, actually. And we have a big minimally invasive and urogynecology division here under the Department of OBGYN. I have no disclosure to announce here. I don't work with the companies. I work only for UTMB. All right. So I picked two topics that I thought you might be interested in. One of them is the urinary incontinence, the leakage. It's an involuntary act, and it affects the self-esteem of the patient, decreases the ability of living the life they wanted to live, and it affects their social life, home life, family life, sexual life, and they put some restrictions on it to avoid those problems. So they put restrictions to themselves, the women. Next one. The urinary incontinence is a very common thing. It's more common than hypertension, diabetes, for example, depression. It always makes it the 10 most common chronic condition and the highest prevalence in the elderly. And I just want to remind you that, we are aging population, so we will be expecting life, it will be even longer when we get older. All right, next one. And when you look at it, even in the young ages, between 15 to 64, 1 out of 3 women has this problem. And when you get older than 60-year-old, that goes over that 1/3, and it becomes actually 1 in 2 women when you look at the special populations like homebound, elderly populations. Next one. It's not only it gets more common as you get older, the symptoms also get more severe when you compare to the age groups. Next one. That's the other way. Okay. Yes. The other next one. Can we move to the other one? I guess we're having. Okay. So when you go to the next time, the Walgreens or CVS, look at the biggest aisle. The biggest aisle would be, the vitamins section, and then the second biggest aisle will be the incontinence aisle. We spent over $12 billion for this issue per year in the U.S. And when you look at the advertisement, they all aim for the women population, actually. Yeah. So the risk factors. What are the risk factors to watch it? Well, if you have chronic constipation, you may have this urinary incontinence. You may develop the urinary incontinence later on. Obesity is one of them. Smoking is one of them. Diabetes, again, one of them. High impact physical activities. Today's women, they work even out in the plant, or they go to the gym and they push themselves, too much with the wrong activities to increase this risk factors of getting an incontinence. The next one. Yeah, certain medication causes the incontinence as well. The next one. And the other factor, the biggest factor, I'll cut the cheese, and it's the vaginal deliveries. When you have the vaginal deliveries, 2 to 3 times your risk of urinary incontinence is going to increase. And if they do forceps delivery or the vacuum delivery, that risk goes even 7 times higher. It's even more higher. And the race is a factor, yes. Pelvic muscle weakness is a factor. And if you are menopausal, that's the age that the estrogen depletes more, and you had a previous vaginal deliveries, so it puts you in a higher risk of developing this problems later on. The next one. So when you look at the causes, again, you can summarize them under 4 conditions that is a setup for the incontinence problem. I will go them quickly for the sake of time here. So affecting the lower urinary tract, meaning if there is too much of dryness in the vaginal area, it may trigger the incontinence. Continuously having a urinary tract infection does that. and vaginal delivery and the chronic constipation. Those are the major things for the woman's health. The second part is the drugs. We already talked about some of it. And there are certain medications and drugs that irritates the bladder. We have the list of those things, and then we will try to avoid that. And the next one, increase the urine output. Some overhydration or congestive heart failure, holds the fluid in the body, and then which translates into the going to urinate more. All right. And some psychological factors may causes this as well, especially in the elderly populations. So that's just the better understanding the setup for the incontinence in the future. Next slide. There are different types of incontinence. We'll go one by one, some of them. Actually, the most common ones, we'll go with that. The urge incontinence. Urge incontinence is when you have the urge to run to the restroom all the time. You go in there, there's not that much of urine comes out. And while you're running into the restroom, actually, and then you have accidents. You have the urine leakage on the way to the restroom. This patient population, it affects their social life so deeply. The first thing when they go for a shopping or when they go for a restaurant, they first spot where the restrooms are because they know that they're going to be needing to run there. And they sit, for example, they ask to be seated in the restaurants closer to the restrooms. It affects, I'm giving that example just to show you how dramatically affects their daily life, actually. All right, the next one, that's the urge incontinence. Stress incontinence, when you cough, when you sneeze, that you leak urine, when you laugh. And that's mostly related to the vaginal deliveries. And then, or the next slide will show you, it could be the both of them. You can have both urge incontinence and stress incontinence. This is overflow incontinence is a different one. Mostly we see in the diabetic patients, and they don't feel that their bladder is full. So it gets to the point that the bladder cannot expand anymore. You start leaking naturally. All right, the next one. That's the functional during intercourse. It could be into certain movements that they leak urine. All right, the next one. All right. So these are the common myths and facts that implies toward the patients and toward the physician. The physician says, hey, look, if she had a problem, when you go for a pap smear, for example, when you're getting your, well woman exam, the doctor fails to ask you about this question, thinking that, hey, look, if it was bothering her, she would have told us. But the fact is, if you look at it, 50% of the women with the severe urinary incontinence do not speak to the physicians because of the embarrassment. And there's another study showing that if you ask the same patient 3 times, that whether she's leaking urine or not, after the second time, the third time, they will tell you, tell you that, yes, I'm experiencing this. Well, the other myth is, it's a natural cause, it's a part of aging type of thing. And who gives that advice? Usually the mothers. When the patient has this leakage problem, goes and asks her mother, and then she convinces that, it's part of aging, it happens to, welcome to the club, it happens to everyone. It's not. Maybe it used to be accepted socially at that time, in their time, but we are living in a different era. And it is not an acceptable position at this time. And, the other concern is, okay, what are they going to do for the treatment? If they do the treatment and, they would think of the worst, that they hurt from somewhere, or it gets worse if you get treatment. It's not true. It's not close to the fact. All right, the next one, please. So thank God we developed better techniques than this 100 years ago to diagnose this type of problems. So they're pouring the water from the poor guy's bladder, and then when the bladder fills and they're monitoring it. So we have better and more sophisticated techniques these days. We can go to the next one. So we have basically behavioral therapy, pharmacologic medication therapy, and surgical therapy. Let's move on to the next one. The behavioral therapy, we teach how to do potty training, and we do physical therapy. The physical therapy is not the Kegel exercise only. It gives the feedback throughout the treatment, and teach you how to do it right. It's a 3 month regimen. After 3 months, if it didn't help, it's not going to help. So that's why it requires really commitment to it. And you visit us, our people, once every other week during this 3 months regimen. But we give you homework, you do it at home, and after 3 months, you give us a report how you're feeling. And that's behavioral therapy. And we give you also what diets to follow, what foods and drinks to avoid. Pharmacologic therapy, there are so many of that, and we try to pick the one that suits for you as an individual, comparing the side effects and everything. So let's move on to the next one. Interventional treatment. When you say surgical treatment, interventional treatment is actually a better way of putting it. And it's not only surgery. Before the surgery, there are certain procedures, certain things that we can offer you, that we can do it in the clinic. The next one, for example, the Botox treatment. It helps. It's the best treatment, one of the best treatment technique actually we have in our hands right now. And we inject multiple places inside the bladder. It helps almost 80% of the patients. The next one, and we do it in the clinic under direct visualization. And if you are interested in, you can watch from the monitor inside your bladder as we're doing it. It's like a 2-3 minutes procedure, and it helps you to cover it 6 months or so. And if you're happy, you'll be coming back every 6 months that we can repeat this. The next one is a bulking agent. It's an old technique, but then we developed a newer approach to it to make it more comfortable. It can be done in the clinic. It can be done in the operating room. Again, it's an injection to make the bladder neck really strong so you won't leak urine. And it's 2-3 minutes thing for the procedure as well. And let's move on to the next one. The last one is the most new one. The pacemaker for the heart. So the same deal, same technique that they made it for the bladder. So you see those big bladder nerves coming from the tailbone area, and actually Miss Milborn is the expert, and she puts it in the clinic. If it works, 1 week or 2 weeks later, you are the judge. As a patient, you come back and you tell us that, oh yeah, I loved it. Or you say, you know what, it didn't help me that much. I didn't like it. No harm is done. The electrode will be pulled out and you'll be walking out of there. But if you say that you liked it, yes, then we can hook you up with that, put a battery under your skin, and then you'll be good to go at least for 5 years. And that helps tremendously for those patients that failed from the medication treatment or those behavioral or those classical treatment modalities. Okay, the next one. This is another technique, and you come here, it's like a acupuncture that we put it into that where you see the electrode. It keeps sending an electric stimulation to your bladder through your leg, because it's the same nerve travels all the way to back to bladder. And it's a 3 months regimen, and it requires for you to be here and bring your book with you while we're doing it. You read your book 10-15 minutes every week for 3 months period. You see, other than the classic surgeries, we have so much of other modalities to offer for the incontinence problem as well. Yes, we offer the surgeries as well, and those are all same-day surgeries that you go home the same day. The next slide. That when you come in on the initial visit, will paint the whole picture for you, so you would know and you can follow it from your handout. Look, we are trying this stage now. If you are not happy, we are going to move on to the next stage. If you are not happy, if you're not satisfied, we are going to move on to the following stages. So you would know actually what we are doing. And even before you come here for your next appointment, you will know what stages that we are going to be offering you. So you will be monitoring your services, and you will be involved with your treatment. That empowers you. So the surgical treatments we will discuss in person. It's because it's more tailoring thing. So you cannot offer the same surgery to everyone. And we have to tailor the surgical option based on your needs. All right, let's look at the next one. This is for the incontinence part. And if you have any questions, I'll be happy to answer it. I wanted to add this chronic pelvic pain topic to this talk. I felt I was obligated to mention it, and you will see why it's important that I felt it that way. And if you have more questions, you can ask later on too. But chronic pelvic pain, it's a pain. It's been going more than 6 months, below the umbilical area, below the belly button area. Any pain, it's considered a pelvic pain. Okay. And it could be continuous pain, it could be related to your periods, or it could be, random pain. All right, next one. Why? Well, why is that important? Look, that's 20% of women involved with this chronic pelvic pain in their lifetime, one way or another. So it's another common problem that women doesn't seek for help. And when you look at it, 40% of the laparoscopic surgeries done for this problem. It is a wrong approach. I will tell you that the surgical option for this type of patient should be the last resource. So, it's been mistreated. That's what I'm trying to point out. It is important, especially for this group that, I'm talking to, 45% reduction in the work production because of the chronic pelvic pain, and 15% increase in time lost from work because of the chronic pelvic pain. And you will be familiar with if you are working in the environment that your manager is a male, and they will say, oh yeah, again, it's a female issues that, she didn't show up. So it's a fact, it's there, and it affects a vast, a lot of people. And ethically, I felt obligated to mention it because 40 to 50% of the chronic pelvic pain patients, they have a history of abuse, physical or emotional. So they come to the ER for pain purposes, pelvic pain purposes. That is only, most of the time, that is the only time for their accepted visits outside their home or work area. So as a physician, we should be doing a better job on that, exploring that when we see these patients, rather than treating them that, oh, they're seeking for drugs. And when you look at it, 30% of those patients have urinary symptoms, and 20% of them, they have got the gynecologic symptoms. So 50% of those patients, they have related issues with my area, but only 50% of them. So you cannot just say that it's not a gynecologic issue, it's not my problem anymore. And the treatment is the multidisciplinary approach. And we provide that multidisciplinary approach here with putting all the different specialties together and treating those patients and trying to help those patients out, as well as we do the same thing for pelvic health issues. And we have urologists on board, colorectal surgeons on board, GI doctors on board, physical therapists, psychology part of it, pain doctors on board to help those both pelvic floor disorders, meaning incontinence, prolapse, and also pelvic pain patients. Minimally invasive surgery is the way to go, generally speaking, for gynecology. And it's not only for cosmetic reason. The cosmetic reason is a valuable reason. However, it's not the only reason. It's an early recovery, early go back to work, early go back to your daily life that improves the quality of life. So when you are offered an open surgery and somewhere else, just come and get a second opinion from us. We might be an help for a different approach for that matter. So the last slide, I will thank you. And these are the contacts that you can contact us, and we'll be happy to help you. Sometimes with the telemedicine, we do that. And telemedicine is a new thing with the COVID stuff. We started doing it. But some of our patients, they prefer that way and as an initial contact and or for the follow-ups. And we will be happy to, provide however you feel like it. Well, I'll just stop here. And if you guys have any questions about the incontinence, pelvic floor, any issues related to women's health, pelvic health, I'll be happy to, I'll try to answer.
You want us to field the questions here?
Yeah, sure.
Okay, great. So we have a few questions, Dr. Killett.
Okay.
The first one is, at what point should a woman seek medical attention for urinary incontinence?
Well, one thing is when you have the symptoms. That's one thing. The other thing is when you're getting a well-woman exam with your gynecologist, ask the questions that, do I have a prolapse? Because the prolapse in the early stage, and you're not gonna feel that much. But then during the pap smear, your gynecologist would be able to observe it. So you can be active, and after the well-woman exam, you can ask that, do I have any early signs of prolapse? That's one thing. The incontinence is, and don't ask your mom, ask to an expert first, and then bring your mom to us, and we'll talk. We'll convince her that it's not like a natural thing, that it has to happen to every woman as we get older. All right. But if you have the symptoms, definitely you can contact us directly. But then if you have mild symptoms, talk to your gynecologist about it.
Okay. Can you talk a little bit more about prolapse? Just kind of define what that is, what we should be looking for.
The prolapse is the vaginal, the pelvis is like a cone shape. So that's the disadvantage of the woman's anatomically, that when you cough, when you sneeze, every time your abdominal pressure goes up, it radiates into that funneling area, funnels into over to the pelvic area, and the weakest muscles, it's around the vaginal area. So it damages those muscles, and especially on top of it, you had a vaginal delivery. On top of it, you become menopausal at that point, and then the vaginal walls starts coming out through the vagina. So the bladder pushes into the vagina, or the rectum pushes in toward to the vagina. They all try to come out through the vaginal hole. So the early symptoms will be during the intercourse. Your partner may say, or you will feel pain, or your partner says that I'm hitting something that, it wasn't there before. And if you let it go, if you just ignore it, after a while, you will see, when you're taking a shower or so, you will see something actually looks like a tennis ball that is trying to come out of the vaginal opening. You will be seeing, observing it. And if you ignore it further, then it comes out all the way, then to the point that you won't be able to sit. You will be pushing with your hand toward inside, so you can sit. And if you stand on your leg long enough and in your feet long enough, then it will start putting a pressure in the pelvic area. So those are the symptoms that you should be watching.
Okay. And are there permanent solutions to the issue?
Well, then we stage them. It's like the cancer staging from 0 to 4. 4 being is that everything is out now, and then earlier stage the better treatment options we have, meaning we may avoid the surgical approach, we may go with the behavioral therapy, we may go with the physical therapy, and or we can use some small procedures to lift up those, the bladder or the rectum, create the vaginal muscles again. So that's why my area is called reconstructive pelvic reconstructive surgery. It not only fixes all the, the vaginal the prolapse problem, but also it's a fact that scientifically shown that it also improves your quality of your life and your social life and your sexual life when you fix it, when you treat it.
Right, right. Okay, we have a question from Tiffany. Dr. Killick, does urinary incontinence start slowly and progressively get worse, or does it come on all at once?
It depends on the patients. Like if the incontinence started right after you had the delivery, okay, you had a vaginal delivery and you become incontinence, there is a chance that 30%, I won't give a number because it depends on the age group as well at that time. But it's more likely that it will improve in the following 6 months. But that improvement is temporarily, most likely. But we don't treat those patients. We just do a physical therapy with those patients, group, for example. But if you get to the menopausal area, you started leaking urine, yeah, that is probably is going to get worse. But if you're an elderly patient population, when you're getting closer to the 70s, over 70s, then on top of it, you also have a prolapse. Your bladder is falling down, okay? Your bladder is trying to come out of through the vagina, the vaginal opening. So it kinks the bladder neck, so your incontinence relatively gets better because it's nicking the bladder neck, so that's why you're not leaking as much as you used to leak. But if when we fix the prolapse, your incontinence will surface. So that's what I'm saying. It really depends on the age group, and it depends also whether you have prolapse along with the incontinence together. Does that make sense?
Mm-hmm.
So everybody's situation, the prediction changes for everybody.
So you talked a lot about moms and daughters, and does that mean that urinary incontinence is a hereditary condition, or if your mom had it, are you doomed by fate?
That's a great question. There's a study, they did it in the identical twins. And it shows that actually if one of them has incontinence, the other one has two. All right. So there is a genetic component that shows that there is a genetic component into that incontinence thing. Yes, it increases your risk of having an incontinence or prolapse if your mom had the same problem. However, they did the study on the twins, and one of them had a C-section, the other one had a vaginal delivery. And they followed that the more commonly in the vaginal delivery group had an incontinence, the other group did not have incontinence. The C-section group did not have it. So it shows that it's a multifactorial. So vaginal delivery is one of the component, but the genetic is the second most common component to it. You're right.
Okay,
that's a great question.
Okay. Then we have a question here about bowel control. What does physical therapy involve, and does childbirth or repeated heavy lifting or straining, can that cause this issue?
That is more complicated than the urinary incontinence. And that's why we have the multidisciplinary system here. And behavioral therapy plays a bigger role on that one, and medication included in the medication. And we need to keep, our aim is to keep the bowel consistency, the fecal consistency in the certain level. We don't want it to be too loose, we don't want it to be too hard either, because the chronic constipation messes up all the rectal muscles along the years. And then vaginal delivery, during the vaginal delivery, if they have a tear all the way from the vagina to the rectal area, that's more likely those patients will have that type of problem when they get older. That's another risk factor for fecal incontinence part. And there's a functional part of the problem. There's also anatomic part of it, meaning the rectum is started falling down. That's a anatomic problem. When we fix that anatomic problem, with then it goes away. But if it's a functional problem, those are the patients that will lean more toward to the behavioral therapy and medication therapy and physical therapy.
Okay.
I don't know if it answered your questions, but it's part of the picture though. So for those patients, for example, with the severe anatomic problem, we have a colorectal surgeon. She's a great lady and she does a great work. So we do combined surgeries with her, and she pulls out the rectal part and repairs the rectal muscles that were torn. And we repaired our urogen part. We repaired the vaginal muscles at the same time. Usually, think the pelvic muscles as like a hammock. If there's a tear in the hammock in one part, that tear is going to get bigger, and it's going to go all the way from one end to another end. All right? So you cannot just say that, oh, this is my part, I'm going to fix that, and I don't care the rest of it. No, you have to address the whole entire problem at the same time.
Okay, that makes sense. So we had a request from Shayna Pearson to make a comment. I'll open it up to you, Shayna. You're on mute right now. Can't hear you.
How about now? Can you hear me?
Yep. Yes.
Okay, there we go.
Yeah.
Hi, Dr. Keelik. I'm actually a former patient of Dr. Keelik's, and so he did my hysterectomy, and I just want to share with you, he has a great presentation. He's very serious, but in clinic, he is so easy to connect with. He has such a big personality, and you'll just fall in love with him. So please do not hesitate.
And we pay her to say that, by the way, for the other rest of the
No,
Yeah, the
and
check's in the mail.
So he just took very, very good care of me. And at the time when I was doing the hysterectomy, my son had just been diagnosed with epilepsy. So I just wanted to ask Dr. Keelik, do you remember Tristan when he was he was invited to the back to go do a robotic surgical simulation, and it went online. I still have that picture of you and Tristan together doing the online surgical simulation. So he wanted to see how well my son would test, because he plays games, all these gamers that we have as kids. And it was for the residents to train on the simulation. And so Tristan actually scored pretty well, right up there with the residents.
Yeah, that's true.
Great.
That's true.
That's crazy. Yeah. The kiddo can do it too.
Yeah.
It was a lot of fun.
That got so much of attention. I got interviewed where was it? Like different countries. They called me for that. We finished that. That
Because
actually,
the kid had done it.
Inspired me to do that study. And then we did the study. We compared all these physicians to the gamers, and they do gamers actually 10-year-old, 12-year-old kids. They do as good as the surgeons. So that's a different world.
Who knew, right?
Yeah, who knew? I was just trying to cheer him up, and then that's why we started playing. And then I realized that.
Yeah, I still have that picture of you and Tristan together on the surgical simulation working that. So that's a memory that we'll cherish forever. But thank you so much. I just want to let you know I'm good and healthy, and everything's going really well on my side. the hysterectomy. Ladies, that was a gift to myself, and it was the absolute best gift I've ever had. No complications, quick recovery, and again, the very, very best care from Dr. Keelik, truly.
Oh, thank you,
Thank
Shana.
Thank
We
you so
appreciate
much.
that.
I appreciate you. Yeah.
That's right. Are there any other questions out there? That's everything that we had in the chat box. Feel free to open your mic and let us know. April has a question.
Go back. Dr. Keelik, you talked a lot about physical therapy, but can you a little bit more about what that entails? How do you do the physical therapy? What is involved?
We have two experts, both of the ladies that they're really good at this. They put, again, when you have an EKG in the heart, the similar electrodes, they put it in the perineal area. So those electrodes are hooked up to a computer. Computer picks up the inner muscles activity. So the Kegel exercise is aimed to work your inner muscles to compensate the ones that is not working. But if you were not trained how to work those muscles up, you wouldn't know how to work them up, okay? So that's why while you're doing it, they teach you, okay, like, why don't you do it this way? When you do it, and the computer gives the feedback and says that, no, she's not doing the right way. So you try different angle until we find the right way of doing it. Once you do it, we go like, okay, repeat the last one you did it because the last one was the right one. And when you do that a couple of times, then you develop a memory. Your brain develops a memory, learns how to work your inner muscles. So you go home and keep doing it, but doing it the right way this time. So 2 weeks later, you come back, they give you different sets of exercises. And then they also follow up, monitor your progress throughout this treatment. So it's not an invasive technique or anything.
That's interesting.
It's like going to the gym for your pelvic muscles. So
that's what I'm afraid of.
No. Workout is a good thing.
Okay, we have another question here. What are your thoughts on BHT pellets for hormone imbalance? It's changed my life, but it comes with a black box warning and worries me.
Well, that is I'm not really familiar with it, actually. I can get the expert from our department to talk about it for hormone replacement therapy. The hormone replacement therapy, the only thing I can add to you is for our end, for the pelvic floor muscles and the incontinence muscle, the bladder base has also estrogen receptor. So when you are very dry in the vaginal area, we use a cream, the estrogen cream, and it does not increase the level that you should be concerned for the breast cancer issues. When I was at MD Anderson, even for the breast cancer patients, we were using for 3 months period, and it is not a concern. But it helps a lot to improve your incontinence problem if you are really dry down that area. It also helps for before the surgery, we give that cream to improve your recovery after the surgery, as a matter of fact. So, and that's the only part that I can add to the hormone replacement therapy from my end. But we have a menopausal clinic, and if anybody is interested in, Dr. Snyder is the head of it, and he has a clinic in Clear Lake Hospital at UTMB that he will be happy to review all those facts with you guys.
Thank you. Thank you, Dr. Keelik. Those are all the questions that we had come in on the chat. So Jessica, I'll turn it back over to you. Thank you again for allowing UTMB to be a part of Women in Business. And thanks, Dr. Keelik, for making this such a comfortable conversation for all of us.
Absolutely. Anytime. Well, thank you very much for having me. Bye, guys.
Got it. Thank you so much. We have a couple minutes left, so if we want to kind of go around, if you have any, announcements or want to do any introductions to yourself, just let us know what's going on in your world and your business. Feel free. We will open the door to any open discussion. So, yeah, go ahead, Gina. Oh.
Can you hear me? Oh,
Yeah,
here,
yes.
am I back? Okay. New system, sorry. So I am a member of the Texas City Lamarck Chamber because I no longer work at UTMB. I'm no longer under the direction of Dr. David Callender with that team. I had to transition to homebound services because Tristan's epilepsy is out of control and he's having weekly seizures, tonic-clonic seizures, and he stops breathing with his seizures. So he's at very high risk of SUDEP, which is sudden unexpected death in epilepsy. So Tristan, after he received his Eagle Scout, he decided after a 5-year partnership with the Epilepsy Foundation Texas, running a support group with his mom and some others, we transitioned into starting a nonprofit to support our community, to better support our community. And I'm very excited to share that we have our first grant that we're going to start awarding every year that's going to go to a college student that has epilepsy. And I'm really excited to share that we've partnered with a foundation out of Chicago, Illinois, that raises awareness of SUDEP. And we are going to be sending a family next year to Epilepsy Awareness Day Disneyland. It's the same trip that Tristan took in 2015. And so this is our way of paying it forward to be able to send another family. And our goal is through our nonprofit for epilepsy is to send a family every year to this event. It was canceled this year because of COVID, but it will be online. And so we're hoping that next year is going to be the year that we can actually send a family. So Tristan's story is, if you look at under my name, it says gceatx.org. His story is there. Tonight is our support group meeting. This is our 6th year doing a support group meeting for our community. And we're really excited because we have a mom warrior that fights for those with all kinds of disabilities. She's speaking tonight. So if you want to join us, go to our resource page, our events page. And we have all the details. It's a Zoom link. She's an inspirational, motivational speaker, and she just is amazing. So I'd love for you guys to join us tonight if you're interested.
Would you be able to send us the invite?
Yes, I will. Of course, Dr. Keelik, I will send you an invite.
Yeah. That would be great. That would be great.
I'd love to
hear that.
Tristan was actually covered by the New York Times at one point through this path that we walked. So if you'll go to that website, gceatx.org, and there's a tab that says founder, and it's his story, and it's all the publications and all the articles and everything that he's been involved with for 6 years. So he's done some amazing work.
G, hold on, repeat it again, please.
Yes, G for golf, C for coast, E for epilepsy, A for alliance, and then TX for Texas. We had to throw in the TX there for Texas.
Yeah, you got it. Okay, good. Thank you.
Yes.
Thank you for the information.
Yeah, connect with us, Dr. Keelik. Tristan will be on tonight, of course, as always. And this is just an extension of our family. We're all challenged and touched by those with epilepsy. It's 1 in 26 that will be diagnosed with epilepsy, and 1 in 10 will have a seizure in their lifetime. So if you don't know seizure first aid, get in touch with us, because you want to be able to save that loved one, that family member, that aunt, that uncle, that cousin, because 1 in 10 will have a seizure in their lifetime, and we'd love to be there to help you through that.
Good work. Good work.
Yes, congratulations. That's really exciting news about the grant, and it gave me chills, when you said the paying it forward with the Disney World trip. That's awesome. We love to hear that.
Yeah.
Who's next? Jody, do you have anything to share?
This is my first time to be on one of these, so I thought I'd at least.
Welcome.
It was a great topic. At first I thought, I don't really need to know this stuff, but yeah, I'm glad to know some of that. I'm with College of the Mainland. I work in our advancement office, and our big premier project we're working on is the Promise program. It's the Opening Doors Promise program. And so what that does is it provides free tuition for recent high school graduates. So we're launching this fall for Hitchcock, Lamarck, and Texas City. So we're really excited about that. And then we're working to fundraise so that we can also offer that opportunity for Dickinson and Santa Fe next, but we've got to raise some more funds to do that.
Very cool. Very cool. So our students, what's kind of the latest with students, starting classes this fall at COM?
All online.
All online.
Yeah, there will be a few science lab activities or some of the P-TECH programs that have to do some hands-on things. And so they'll be spacing those out by appointment only on campus. But for the big general population, it'll be all virtual learning.
Gotcha. And Lauren was so sorry that she couldn't join us today. So speaking about the virtual learning, both of her sons started school today, virtually online. And so they're in junior high and high school. And so she had to make sure they were able to log on for every period and, make sure they're there and accounted for. So yeah, definitely a different world as we're starting this, this school year. Even from the spring, I have 2 little ones that are starting in a couple weeks, and we're just taking it day by day. So
That's right.
Yeah, I heard your story already this morning. My son has some friends and they were making fun of some kid because his mom was right in the background, push that, do this.
right. Very good. Well, we're happy for you to join us. Let's see who's next. Tiffany, what's going on down on the island?
I will let you all see my face today. Hi, good afternoon. Thank you, Dr. Kulik. I'm actually a patient of yours for a while, and thanks for the reminder that I need to come in. As far as on the island, it's a little different. We're very fortunate that we are a drive destination that, people are familiar with, and we are a beach destination. So, many people try it out. However, on the flip side to that, again, Tiffany Gonzalez, I'm with the Galveston Island Convention and Visitors Bureau. That basically what I do is bring conferences, events of all sizes, all types to any place in Galveston. Right now, it's just a struggle to keep conferences coming. Not only is it just the safety, but some of them are too big to actually be social distancing to actually host. So there's just the challenges. However, very, very optimistic that, people still want to meet face to face. However, now with the social component, it's now easier to connect with a lot more people. And, it's going to be very challenging moving forward. But, hopefully everything will work out on the end. As far as Galveston, we're doing well. Everyone still loves to come, so that's a good thing. But that's it.
All right.
Perfect.
Well,
and if anybody wants to drop, oh yeah, go ahead.
Yeah, when it opens, the island, I mean, this social distance thing goes away, and that would be a good topic. Covering some sort of a pelvic health gatherings, and in Galveston, and then that will be an opportunity to show the islands. And I'm talking about the population coming even from the Houston, from Alvin areas to join us for a day. It could be like a cookout type of thing as well. So it doesn't have to be like a formal
Absolutely,
thing.
absolutely. And I'm your contact too for UTMB. So anybody that that is trying to host anything, please give us a call. We offer a lot of support. But yes, those are exactly the opportunities that I'd love to work and partner with UTMB.
Great. And Tiffany, what's your email address?
Thank you.
So people can reach out to you.
We'll type it right here in the chat box.
Perfect. Okay, does anybody have anything else? No? Well, we will go ahead and close it out. Again, thank you so much, UTMB Health. You guys, have provided so much valuable information over so many different topics, through this series, and we appreciate partnering with you. Thank you, Dr. Kulik, again, awesome information. Kind of like Jody said, information I didn't think I needed, but actually got some pretty useful nuggets out of there. So
Now
yes, exactly. So we will send out information about our next meeting next month. And as always, if you guys have anything that you need help with or just want to connect with us here at the Chamber, we are here in the office. So just give us a shout. So,
Thank you, Jessica.
everybody,
Bye,
have a good
everybody.
afternoon.
Bye.
Good afternoon.